Dr. Marianne Gausche-Hill, did I pronounce that correctly? Visiting from UCLA, where she's a full professor of emergency medicine. She's the EMS director for LA County, which I believe is the largest county system in the hospital. Thank you, Steve. And she's an educator and a researcher in EMS, more so than pediatric EM, and the recipient of numerous awards, most notably 2004 ACEP Award for National Educator in EM, and was named in 2008 again by ACEP as a hero of emergency medicine. So please welcome her.
I'm having my caffeine equivalent here, Diet Coke. Everybody has to have some stimulant. Hopefully caffeine is it. But thanks. I've been here one other time for Trauma Symposium, and that was a great talk. The last two presentations, case histories, were excellent. We see a lot of penetrating trauma as well, so it's kind of, those issues are near and dear to all of us in emergency medicine. What I thought, first of all, I don't have anything to disclose, which is unfortunate. It'd be nice to have something to disclose, right? You say, you've developed this great, tool that you now, you can retire on, but it's not the case. What I thought I would do with peds airway management, this is something that I feel pretty strongly about in terms of how you maintain your skills over time. Critically ill and injured children are relatively rare. We see a lot of critically ill and injured adults, but we don't see a lot of critically ill and injured children. When you think about it, I don't know, when you graduate from your residency, how many peds intubations will you have done?
One.
Yeah.
Required number to graduate.
So is that enough to really be proficient? The answer is probably no. And so every residency is going to have the same problem. This isn't unique to your residency. We have the same issue at Harbor. So as I go through this, I'm going to try to help you with some pearls on how to maintain your skills over time. Okay? And one is to seek education, of course, and practice sessions, but the other is you can practice cognitively on every shift that you see children. And so here we go. I'm going to give you an update, and then I'm going to try to kind of work you through some of those other issues. So what's new? Cricoid pressure, which was, we think about using that to help visualize, to be able to visualize the airway, or doing bimanual Laryngoscopy, right? You do bimanual manipulation while you're doing your direct laryngoscopy. And it's really not recommended. I haven't used it in children in many, many years. So in 2010, when American Heart came out with their initial guidelines saying, hey, maybe this is problematic, I was like, right on. I never use it in children. And the reason is there's some anatomic differences, right? The trachea is less calcified, so not as stiff, and when you put pressure on it, basically you just cause collapse of the airway. So I find it more problematic than I find it helpful. A take-home will be jaw thrust is the bomb, okay? Is your friend. Doing a jaw thrust in kids may help not only visualize the airway, but certainly open the airway. An emphasis on back mask ventilation. Every single person in this room should practice back mask ventilation on a child. You gotta know how to do it, and I'll give you some tips on not overbagging, which is generally the rule. Cuffed endotracheal tubes are preferred. Atropine in your RSI algorithm is probably out. I don't use it routinely at all anymore. I do have it available in case there's issues. And as was mentioned in the case in which you have hypovolemic shock, and you're talking about taking away any adrenergic drive, that you could bottom somebody out, put them in cardiac arrest. Now this patient is near arrest, and you need to get the airway secured, and I understand that. But there are situations that I've had with kids that come in hypovolemic or septic shock, in which I have opted not to intubate right away. They've had their airway open, okay? Put them on 100% oxygen, and I'm pushing fluids into prior to intubating them. The reason is I know that with kids, once that adrenergic drive is gone, they bottom out and they'll arrest. So if you have a really sick kid who's in hypovolemic shock or septic shock, which is probably more common, but sometimes hypovolemic, start, if you can, fluid resuscitate them before you do rapid sequence intubation, okay? High flow nasal cannula. With that article by Dr. Weingart that came out now as Emergency Medicine 2011 really opened our eyes to trying to decrease hypoxia that occurs during RSI, especially during the apneic period. We don't really have great data on children. I'll give you some hints on what to do. You could probably do 15 liters on everybody, but infants, I go 5 liters per minute, and older patients I do 15, but there's no good guideline on that, and I'm just telling you the way it is. Less etomidate, more ketamine, as was mentioned before, to try to maintain mean arterial pressure. Children tolerate the ketamine really well. The other thing that should, yes, question.
Sorry to interrupt. I just literally on my last beat shift at residency had a sick kid who we were considering, and we were discussing meds, and the pediatric attending was like, we still worry about the laryngospasm, sort of fear complication
ketamine?
of ketamine. And I sort of tried to dissuade him that had sort of fallen, that myth that sort of fallen by the wayside. What was your thought?
Well, it's fairly rare. Steve Green has the largest series of that, and over 1,000 cases in which it's about 1 in 1,000. It happens like we have a PCD and we see about 25,000 kids a year. And I've heard of maybe 2 cases in 30 years of laryngospasm, so I think it's pretty rare. If you're going to intubate anyway, it really doesn't matter. You just give it to them, and then you paralyze them with succinylcholine only, and you should be fine. Generally speaking, with laryngospasm, there's some tips. You can put pressure on it's called the laryngeal notch, which is essentially where the earlobes are, and if you push, it actually hurts. And you do jaw thrust to open the airway and do positive pressure ventilation. If that doesn't work, then you would give them a paralytic and intubate them, okay? So to me, it's not a concern. I just don't worry about it. I know it's there, but it's a rare complication, and I know what to do if it happens. It's actually never happened in my 30 years of practice in PTM, which is great. And I've done at least 1,000 doses of ketamine, either for sedation or for RSI. The difficult airway algorithm, the good news is, at least from the NEAR, the National Emergency Airway Registry, looking at emergency departments, we're pretty good overall at intubating. Unfortunately, our first pass rate isn't so good for children, and I'm going to give you hints because I think I know what's going on. After watching residents intubate for many, many years, I can tell you what I think that they do, some of the kind of the pitfalls in the initiation of intubation. So we'll start with a case. A 9-month-old boy brought in by paramedics with history of fever presents with seizure at home, so this is really common, right? 1 in 20 children will have a febrile seizure before the age of 5. On arrival, the patient has stopped seizing but also stopped breathing, and oxygen saturation starts dropping like a rock, which is typically what you see in children, high metabolic rate, and once they go into the apneic phase, then O2 sat drops pretty precipitously. So what do you do now? What's the first thing you would do? Bag them, good. I would position the head, open the airway, and begin bag mask ventilation, right? So that's what you would do. So again, one of the things, the reason I say position the head is I see kids with their heads flopped over to the side and people try to bag them with their neck flaxed. And you want to position the head in sniffing position. Sometimes you'll put a bump under the occiput, sometimes under the shoulder, but position the head in the midline, open the airway, you can do a jaw thrust maneuver, and then you're going to begin bag mask ventilation. The other things to think about are going to be airway adjuncts to keep the airway open, depending, so I'm meaning oral or nasal airway. In a kid with a seizure, I would not initiate an oral airway because once they stop seizing, they might gag, and so I typically don't do that unless they're actually completely unconscious. Suction is your friend, so suctioning the airway is important, and bag mask ventilation you initiate pretty quickly. I would not move to endotracheal intubation immediately. I would try to bag them a bit and see if that takes care of the problem. Most of the time I find in seizure kids, unless they're full-on status, they keep seizing, that you do not have to intubate them. Once the seizure stopped, you can bag them out, and they do pretty well, okay? They do very well, in fact. And again, when you approach a peds airway problem like this, you want to do it in a little bit of a stepwise fashion, right? You don't want to go straight to ET with potential complications of ET, when indeed you could do it with just positioning and doing bag mask ventilation. So that makes sense to me. And then finally, you think about endotracheal intubation over time at a difficult airway algorithm. You should have a plan. I assume here you have a difficult airway kit. Do you use Glidescope or CMAC, or what do you guys use here? Glidescope. Okay. And you have pediatric sizes for your Glidescope? You do? Okay. And you probably have LMAs, maybe LMA Unique or Supremes or some other AirQ, or you guys have those LMAs? Or
We have them.
I think it's just LMA. I don't know about the PEDS.
It's all hanging on the back wall in their trauma bays there. Right, there's LMAs, ET tubes.
Okay, LMA, ET tubes, okay. So I'll show you how to put an LMA. LMAs are pretty easy. There's a few little tricks to LMAs, but they're overall easy, and it's a great thing if you can't bag somebody and intubation is problematic. So we'll talk about a situation when that might be the case. And then you want to reassess each time. So here's positioning the head. You want to keep it in the midline, avoid excessive either flexion or extension, just for the reasons I outlined. They have, young babies, they have relatively shorter necks, more soft tissue, very flexible tracheas, and so if you really hyperextend a baby, you can actually cause some airway compromise and kinking. So you want to put them in the sniffing position, as you can see here, and the nurses just know when a baby's coming in, they just hand me a towel, because they know I'm going to want a towel. And it's nice because I just do a little roll of a towel. You can get it about an inch or so, and if you notice the head's flexed here, you just put the towel underneath that, and it keeps them in the sniffing position. The jaw thrust, in my mind, is extremely useful. We've had several patients come in not breathing. We jaw thrust and they start breathing, put them on oxygen, done. Okay, that's all we did. And everybody's grabbing the intubation tray, but we just jaw thrusted and everything went okay. And then took care of the problem, which was generally a seizure. Okay, airway adjuncts, as you can see, they come in all sizes. So, oral airways, I almost never use in young children. Older kids, adults, I use oral airways, especially when you're doing bag mask ventilation. But in young babies, I just find I don't need them that much. Okay, the patient should be unconscious. I'll show you how to measure them in just a second. Nasal airways I really like for seizure patients that come in like snoring and you don't want to jaw thrust the entire time. You can drop a nasal airway and that will just keep the airway open. It's really a nice thing to do. There are some contraindications and relative contraindications, but here's how to measure it. You want the flange part there at the lip, just where the lip line meets at the corner of the mouth, basically. This is the bite block. It's parallel to the hard palate. And then the curved portion reaches the angle of the jaw, okay? So basically you can lay it on the side of the face, and you don't want them too big or too small because they can cause problems. To put it in, you just put your tongue blade in and just go directly over, follow the natural curve, and seat it. For a nasal airway to measure, it's from the tip of the nose to the tragus of the ear, tragus being the triangular cartilage here, that's the length. And then the diameter should be no bigger than the child's nair. To insert these, I find people make mistakes all the time in inserting it. A couple things, you want to lube the nasopharyngeal airway. And if you notice, there's a pointy part with, okay, and here's your septum. You always want this part away from the septum. So on the right side, when you put it in, you basically lube it and go almost at a 90-degree angle, and you can just put it directly in. On the left-hand side, you're going to put it in upside down. You meet a little bit of resistance as you hit the turbinates, and just rotate it 180 degrees in position. That avoids scraping the pointy part of the nasopharyngeal airway from scraping the septum. Everybody got that? In adults, people tend to just shove them in. This is why I point this out. In children, it's probably best to do it the way I just explained to you. All right, bag mask ventilation. This is your go-to for airway management in children. You got to know how to size the mask. You want it from the bridge of the nose to the cleft of the chin, avoiding compression of the eyes, which can lead to a vagal stimulus, okay? You're going to attach to oxygen. You're going to do an easy clamp, and I'll show you that, and you're going to control rate and volume. The biggest problem people have, resuscitators have, and I'm sorry, I'm a little hoarse, getting over a cold and a lot of travel. Anyway, it's the control of rate and volume. And I'm going to try to give you a hint on how you can watch that. All right. Bag size is important. I tell when I meet with emergency department staff and to organize equipment, I say take all the neonatal equipment, you put it in one box, and you put it in one area where you know where it is, and otherwise don't have neonatal equipment around any of the other areas, okay? Because what happens is people grab a neonatal bag, and they try to bag a 1-year-old with it, all right? And it's not going to happen, all right? So a 1-year-old is 10 kilos, is going to need at least 100 mils of air in order to get chest rise, and it's just not going to happen, right? It's not going to happen with a neonatal bag, where the maximum volume is 120, and if you squeeze a bag, you're going to get about a half to 2/3 of that bag out. You can't get all of the volume out. So that's why neonatal bags should be, if the baby is birthed in front of you, literally pops out of the woman's vagina, you can use a neonatal bag. Otherwise, my suggestion is don't use them and just have an infant bag. So for most ERs, you have your neonatal resuscitation kit, and then you have infant. I would have an infant and an adult bag at every station, as an example. Okay? If you have a separate PCD, you can do something different. You can customize it, but that's the deal. Now, the other thing is, let's talk about volume. How many cc's does it take to get chest rise? I kind of gave you a hint. What's physiologic tidal volume? What do you set a vent to?
6 to 8.
6?
6 to 8 milliliters.
Anybody? What do you set a vent to?
Say it loud.
6 to 8 milliliters per kilogram.
Okay, good. So it's somewhere between 6 and 10. 8's a reasonable number. All right, let's just say 10 because it's easier to multiply by 10 than 8. So if I have a 3-kilogram newborn, how much air should I be delivering?
30.
Somewhere, right, between 25 and 30 cc's. That's 2 tablespoons are there. So I've got a 1.2 liter bag, an adult bag. You can see how that might be problematic. So how do you know how much air to deliver, right? Can you measure that in your brain? Can you measure that like with your hands? Clinically, what do you do?
Chest rise.
You look for
Chest rise.
chest rise. Okay, so I want everybody to look around the room. All right, just look around. All right, look at people's chests moving in and out. Do you see people's chests heaving like this? The the answer is no, and you all are awake and upright. And so what happens is that people tend to take a bag and they tend to squeeze it really hard regardless, and then you hear all this, the air escaping and the stomach gets distended, correct? So how do you stop that? Okay, so what you do is you want chest rise, but you want just the initiation of chest rise. So what happens in children, you'll see the lower chest, the upper abdomen, you squeeze the bag just until chest rise is initiated. So you'll see a little movement, and then you begin the release phase, okay? So you take the bag, you go squeeze, and then you say release, release. As soon as you see a movement there, then you begin the release phase. When you do that, you're not going to over-bag, all right? I think everybody's seen that. So let's just keep going. So no neonatal bags around. You segregate those for your deliveries. The EC clamp is your index finger and your thumb are on the mask. Those are pushing onto the mask to seal on the face, and the 3 fingers are pulling in on the jawline, as you can see here, these 3 fingers. So this is your C, pushing down and up. And when you stop bagging, there should be a little finger imprint on the child's jawline, okay? So this is the EC clamp, and doing bag mask is as EC, easy, as 1, 2, 3, and that's how you remember that. And that's pretty hokey, but I apologize. In an infant, because there's not a lot of room, you have your C, and you only have 1 finger pulling up on the jawline. Okay, and that's how you do the EC clamp. And it's really a firm grip, all right? Again, we talked about cricotweight pressure in the beginning. I'm not a fan. I don't use it at all in children. I do a little bimanual laryngoscopy, but what I really like is jaw thrust in children. Older patients, 100% we do bimanual laryngoscopy. I would be intubated like 3 people my last shift, and the bimanual laryngoscopy works really nicely. I like to do the modified form where basically if I'm the intubator, I have my assistant put their hand on and I manipulate their hand, and then I release my hand, their hand is there, and I say stay right there while I intubate, okay? But jaw thrust works really, really well. When I'm supervising, I always jaw thrust in adults and children, but it works great in kids because the airway is a little more anterior. Okay, so de-emphasis on cricotweight pressure. All right, so going back to bag mask, we want to control the rate and the volume. You want to give only the amount of air needed for chest rise. So what you can do, as I said, you can say squeeze, release, release, squeeze, release, release. And you'll see in the video, probably squeezing a little too much there anyway. I'm assisting ventilation here. Squeeze, release, release, squeeze, release, release. What is the problem that I see is that people tend to bag someone at their own personal pulse rate. So like you're excited, right? I get excited too, and I resuscitate a lot of children, but it gets you going. So by saying squeeze, release, release, you slow yourself down. We know that excessive ventilation has a lot of problems, okay? In terms of coronary flow, it increases intrathoracic pressure, so therefore decreases coronary flow. And we know in the latest rendition of 2015 guidelines, they're saying you shouldn't be bagging more than 6 times a minute during resuscitations for adults and maybe up to 10 for children. When we look overall at maximum ventilation rates, this is not cardiac arrest, I wouldn't go any faster than this. But I see people going 60 times a minute, sometimes with young babies. So we want to slow it down. So slower rates are better, and during cardiac arrest, no more than 6 to 10 a minute. Okay? Everybody got that? All right, here's a question for you. What's the first time success rate or pass, success rate for peds ETI? First pass success rate.
7.
Anybody know? Yes? Okay, it's 70%. So why is that, do you think? Well, Pardon?
I was gonna say positioning, probably.
Positioning
You
is
know,
good, yeah.
a million
Positioning
different
may be it. Here's some thoughts that I have after doing this a long time. One, the laryngoscope blade, it's a little kid, and you tend to go small. You want to go large. If it looks like it's too small, it is. The other thing is, if you look in and you see the epiglottis hanging down and you can't put the blade in any further, that blade is way too small, okay? So that's a nice hint. So one of it is the laryngoscope blade is too small. So use your Brasso tape. It tells you cuffed and uncuffed ET tubes plus the appropriate size blade to use. And I'm going to give you some hints, okay? And then what I find is that people get really excited, and you know how, I don't know if you've been taught this, but I've been to a number of airway courses, and they say in adults, just shove it all the way in, and then you can back it out, okay? Unfortunately with kids, if you put it all the way in, and you lift up, it makes the esophagus look like an airway, all right? So it's nice and round, and when I show you a picture of the airway, you'll see what I mean. So people intubate the esophagus, and then it takes them a while to figure it out, and then their confidence level goes down, so their ability to intubate the second time is a little more compromised. You want to optimize on the very first pass. So how do you do that? What I do is I tell people, you know, you put a thumb on chin, that opens the mouth, just put the blade directly in, because typically I'm using a straight blade, and we'll talk about that in a bit. Once the blade gets to the base of the tongue, lift up. You're going to see something you recognize, okay? So it may be, you know, the epiglottis. You may have to go a little bit further, but sometimes you're in and perfect. You get a perfect view of the airway. So you don't shove it all the way in. You put it in just to the base of the tongue and lift up, all right? The other one is failure to use jaw thrust to help you with visualization. I think jaw thrust helps you get an assistant to help you. And the other thing is the problem is tube size is too small. People tend to go small instead of larger, all right? And we'll talk more about that in a bit. So really preparation is the key. In some centers, they say you can't use succinylcholine in babies. I say that's ridiculous. I've done it my whole career. And if you just do sedation and you're fighting some newborn or some neonate to intubate, so we know that sedation facilitated intubation doesn't work as well, and the success rate isn't as good. So with children, no matter what the age, consider doing full RSI. If they're in cardiac arrest, as was mentioned before, you don't need RSI. And then you should always have a contingency plan, and generally it is positioning the head, opening the airway, doing back mask ventilation, and trying again. Some of the equipment you need is suction. This just shows a colorimetric device. You can have end-tidal CO2, just the standard capnography. Oxygen, you're going to have ET tube. I would recommend having two sizes. Like 1.5 size larger. And then your laryngoscope blade with appropriate handle. These are pediatric McGill forceps. McGill forceps are used to remove foreign bodies. We did a survey and assessment of the United States and found about 17% of EDs do not have pediatric McGills, which are absolutely necessary to remove large foreign bodies. So you should make sure you have it in your kit here. And when you go out and practice, just remember this, because a lot of ERs don't have them. And then CO2 I already mentioned. All right, so you got all your equipment. You definitely have to have suction. You want to make sure that you use the right stylet. Some people say you don't need stylets. I find that it gets hot around these resuscitations. People are warm and exuding heat. And that endotracheal tube can be like spaghetti. So I always use this stylet, all right? What about tube size? What if it's a preemie? This is what our NICU uses. Now you can have time on a compromised newborn or newly born to determine the weight? The answer is no, okay? If it's about, if it looks like it's term size, just use a 3 or 3.0. If it looks really small, then just get the smallest endotracheal tube you have, which is typically going to be a 2.5 or a 2. But I would say 2.5 is, it would be fine for most premature newborns. Can you memorize this? You can put it on your smartphone, you know, and that will help you. The Broslow tape, remember, it starts at 3 kilos. So if the kid is shorter than the Broslow tape, meaning, okay, doesn't even get up to 3 kilo, then you know you got to use the smaller ET tube. The video just shows how to use it. I think you all are familiar. You lay it out. There's a red arrow at the top. So red to head, the red arrow goes to the head. You lie it flat, and it's at the child's heel line is the estimated weight. You can modify it based on habitus, but generally, if you don't know the weight, if you just use what the weight of the Broslow tape is, you're going to be in the ballpark, and that's really the recommendation, to use the Broslow tape if indeed you don't have the actual weight. Otherwise, use the actual weight. Okay, how about calculating it? It's age over 4, excuse me. Age over 4 plus 4 is the uncuffed, and age over 4 plus 3.5 is the cuffed. I just remember one of those formulas, age over 4 plus 4, right? So, as an example, if you have a 1-year-old, that's 4 1/4, and with the ET tube, you actually round down. So it'd be a 4.0 uncuffed, and then you just subtract a half a size per cuffed. All right. I know you guys are glazing over on this one, so I can see that. So use the Broslow tape, carry it with you. It's like $17 per Broslow tape. I say keep it with you. Make sure you have it in the ED, and that will help you out. I'm going to give you some kind of rough guidelines. This is ballpark size. Said premature, 2.5 to 3. Most standard newborns you can intubate with a 3.5. Uncuffed or a 3 cuffed, okay? So newborn, all right, is about a 3. So remember, newborns weigh on average 3 kilos, so that helps you. 3 kilos, 302, all right? Up to 6 months, it's about a 3.5. Uncuffed or 3 cuffed tube. At 1 year of age, it's a 4. All right, now let's keep going. So, how do you remember this? 1, you need to have aids like the Broslow tape to help you. I like this because it's really easy and you'll get in the ballpark, okay? So 1, 5, and 10, all right, is a 4, 5, 6, or 10, 20, and 30 kilos, and then you extrapolate. So a 2-year-old is closer to 1, so it's probably around 12 kilos. A 3-year-old is probably 14 kilos, right? You can see where I'm going with this. So that's a rough guide. A 2-year-old is in between a 4 and a 5, so a 4.5 uncuffed or 4 cup. Do you see how this is working? So if there's somewhere in between, so 1, 5, and 10 is a 4, 5, and 6 is 10, 20, and 30. And then you can extrapolate. And that gets you in the ballpark. Now, why do I tell you to start thinking about this? I honestly believe that one way you can maintain your skills is through cognitive practice. Here's an example. 2-year-old male comes in with an earache, okay? I look at his ears and all that. I talk to the patient. I find out if truly he has otitis media, but in the meantime, I'm saying, oh, he weighs about 13 kilos. I would use a 4.5 ET tube, uncuffed or 4 cuffed, and I'd use a 2 miller blade on it. And yes?
What's your preference?
Cognitive practice.
I know that the trend is now back towards cuff tubes. Is that what you do?
Yeah. Let's talk about 2. The next one is on cuffs. So and I'll talk about why. So you can calculate for uncuffed, or however you do it best, because I grew up with uncuffed tubes in children. It's easier for me to calculate uncuffed and subtract a half the size. Like that works really easy for me. Or just use the Brasso tape. So when you use a cuff tube, anybody that high pressure to ventilate, okay, really cuff tubes are preferred almost in every patient. Why? Well, the cuff now is the actual cuff itself is made in such a way that it doesn't cause significant pressures on the cricoid membrane, which was the biggest concern, to cause really inflammation and stenosis and subglottic stenosis. We know with cuff tubes now that the incidence of subglottic stenosis is no difference between, really very little difference between cuffed and uncuffed tube. So what's the advantage of the cuff tube? Well, the cuff tube, you've got 30% of a less chance of needing to do a tube exchange because you put in too small of a tube. So there's real advantages to it, and you can use higher pressures to ventilate without significant air leaks. So our PICU recommends for us to do cuff tubes. So we try to do a cuff tube almost in every patient that we intubate, okay? And then respiratory therapy can help you with the cuff pressure and all that. From an emergency standpoint, I wouldn't worry about it. You blow the balloon up, you go about your business, and somebody else can check the cuff pressure, okay? But really, they're much safer overall in terms of tube exchange. What about blade size? And you know, obviously we have curved blades and Mac blades and Miller blades, and there's Wiss-Hippels, and there's several other types of blades that could be used. We typically have Miller blades and the Mac blades. I like to use a Miller blade at least through school age, and I'd even use it in an 8-year-old. But I like to do it up until school age. Our anesthesiologists after age 2 like to switch to a Mac blade. So it's really preference, and when I show you kind of what it looks like when you intubate in a child, I'll go over where the blade would go. As you know, and you know this from intubating adults, is that the Mac blade sits in the vallecula, you lift it up and you kind of indirectly lift the epiglottis out of the way. Because with children, the epiglottis is omega shaped and a little floppier, I find it easier to directly lift it up out of the way with a straight blade. All right, here's a key point. All right, a Miller 0 blade should only be used, again, if you saw the baby being born, okay? If the baby is birthed in front of you, you can use a Miller 0, all right? Otherwise, go for Miller 1. So you have a neonate, right, comes in a week of age with a fever, looks terrible, septic, you're worried about septic shock, you decide to intubate. I fluid resuscitate, you know, by pushing, I take those 10 cc flushes, and I have the nurse push, push, and I count so I know how many have gone in. And then I try to intubate. I would use a Miller 1 in that instance, okay? So Miller 0s can get you into trouble because they'll be too short. If it's, again, a brand spanking newborn, a 0, otherwise a Miller 1, up until about 2 years of age. After 2, okay, you should go to, you can either go to a Mac, like our anesthesiologists. I would stick with a Miller. And then it's a Miller 2 after age 2. And then, again, there's another transition for Miller 3. It's about school age, 6 or 7. If they're in first grade, they get you can go up a blade, okay? So think about it this way. A brand newborn is a 0, or a 0, 0. They're really small, but most of us don't have those. So a 0. Up until about 2 years of age, maybe a little shy, use a Miller 1. And certainly at 2 and above, you're going to do a Miller 2. And then you'll transition about first grade, about 6 or 7 years old. If you go in and look, I'll show this to you in a second. If you go in and look, and I'll show you what you see, then, and you can't really go any further, then you need a bigger blade. All right, what about depth of tube placement? People tend to, you know, kind of shove them all the way in. Is that terrible? The answer is no, but The key is to understand that you've got this vocal cord marker. Obviously, the balloon would be down. You got this vocal cord marker, and so this vocal cord marker should go just beyond the cords. All right, so that will help you, this black line. Some of the pediatric tubes have 3 lines, in which case just get to the middle line past the cords, okay? Now, how else can you do it? It turns out that it's on the Brasso tape. It tells you the depth, how many centimeters of the lip. You know, in adults, what is an adult? 22 to 24, right? That's, every adult is 22 to 24, pretty much. So for kids, if you think about it, if you go 3 times the endotracheal tube size, so you take an average adult is 8 times 3 is 24, right? So let's take a 1-year-old. It's a size, let's say 4. We used a size 4. 3 times 4 is 12, so it's 12 centimeters of the lip. So that gives you a rough idea. So after you intubate, if you got excited and put it down the right main stem, you can just look at the centimeter. You know what size endotracheal tube you put in, and you can kind of guesstimate if it's correct. And then you use clinical guidelines. All right? Now this was what I was talking about. Let's take a look at figure B. This is I go in, and what I see is the epiglottis flopping down. Right? You need to go a little bit farther to lift the epiglottis out of the direct plane of the airway. But if you're in all the way and you can't go any further, your blade is way too small. All right? So if you see this and you're in all the way, your blade is way too small. What you want to see is this or this, right? Now this isn't a mannequin. It never looks this good, okay? And I'll show you. But, you know, you can see that you want to see a full view of the cords. Why? As you insert your blade, you're trying to thread that hole, it will deflect it down into the esophagus. So you really want a clear view of the cords, especially when you're using a Miller blade. All right, so let's take a look at an actual airway. There's a couple things I want to show you. One is, I do this too. See how the flange is to the left part of the philtrum? So I put it in a little bit to the left, and I lift up. And the reason I do that is to give me a little bit more room on the right to put down the endotracheal tube. The other handy-dandy thing that you'll see somebody doing is they'll put traction on the right side of the lip. That is extremely useful. So as an assistant to an intubator, you do jaw thrust, they see what they need to do, you pull on the side, hand them the tube, and off they go. The person who's intubating should have their eyes only on the airway. So I put the blade a little to the left. All right, let's see what happens. I would do jaw thrust and no cricoid here, and then they're going to do some traction. Full lip. Once it gets past, they're going to just stop. See that? They just went past the cords. Now what happens in an actual airway is the pediatric airway looks round. The thing that can help you is those arrhythmic cartilages, right? Because if it's the esophagus, it looks like a nice round uniform hole. And if you lift up, it will look round. But if it's an airway, the lower portion of it will be bumpy, right? The arrhythmic cartilages are bumpy. So look for that. If it looks heaped up at the bottom, you're in the right spot. So how do you assess afterwards? Well, obviously you can use CO2 detection. The standard of care in, I think, the country today is to use some other form besides clinical assessment to assess either esophageal detector device, although I would argue probably CO2 detection or end-tidal CO2 monitoring. So clinical assessment. I always listen over the stomach first. Why do I do that? Well, I want to know, do I hear a gurgling sound? Gurgle, like air, like you have a straw in milk and you're blowing bubbles. Okay, so the straw is your endotracheal tube, and if you're in the esophagus and you blow air into that esophagus, you'll hear that air-water interface, so the little sound. If you hear that come out, what if you hear breath sounds in the stomach? It's a loaded question. But you pull the tube. The answer is no, you don't pull the tube, because in children, breath sounds are transmitted throughout the thorax. If I hear breath sounds in the stomach, I'm okay with that. I am not okay with the gurgling sound. If I hear gurgling, I'm out of there. Boom, out, begin bagging, and start again. All right, even before I looked at the CO2 detector, or I look at the waveform, because you know you're not in if you hear that. If you hear breath sounds, continue your assessment, because you're probably still in. You're going to use, do you use a colorimetric devices here? Okay. So you're looking for that, you know, the change from purple to yellow, right? So purple when oxygen is flowing through the device, and then on exhalation it should go yellow. If it remains purple and the patient has a pulse, you have a problem and you need to pull the tube. Are you using esophageal detector devices? No. Okay, so I'm not going to go over those for right now. And then a chest radiograph is like at the very end to just see what else is going on. But you're not going to, you're going to need to act before a chest x-ray is done, right? So if you're not in the right spot, you need to know it before somebody does a chest x-ray and says, oh man, it looks like you're in the stomach on this one, you know? You would never wait. So you're going to use CO2 detection and your clinical assessment. And pulse oximetry, of course. Complications post-intubation. Don't be too vested on your own skill set. Meaning, I've had situations where the resident's going, I saw it go through the cords, it's in, and I go, your patient is arresting, take it out. And then we begin bagging again. Okay, so don't be vested. I've done the same thing too. I remember I had a case and I go, God, I knew it was in, and then I said, Marianne, get a grip on yourself. Your ego is not as important as this patient's life. Let's just take it out. And so that's what we did. So what are the complications you can remember by the mnemonic? You probably had that in PALS. But dislodgement, obstruct dislodgement could mean it's actually in the esophagus. Obstruction, or lack of oxygen, so you may want to make sure your O2 is hooked up, and you may want to suction using a little saline. Pneumothorax, as it happened in this case, and then equipment failure. If a patient's put on a vent, especially kids, I always find that vent settings are problematic with children. If you put the patient on a vent and they start deteriorating, the first thing you do is you take them off the vent, you know, if the ET tube is in place, and just start bagging through the ET tube with a bag mask device, okay, or bag mouth device, all right? And oftentimes, if the vent settings are the problem, the patient will recover nicely, all right? Anybody have that situation? No? Okay. I've had it any of a number of times.
I had it once over in the CAT scanner. The CAT scanner vent was not set up properly as opposed to
Adjusted.
our other.
So just remember that. That's if a patient starts deteriorating, take them off the vent first and start bagging them. That's what I do, and then obviously reassess for placement. All right, for foreign body aspiration, what we typically do, you hear about a patient coming in who's aspirated a foreign body. And so there's two types of maneuvers, BLS and ALS. We typically go right to ALS because we're ALS providers. Just to tell you, because the trachea is flexible, if it's a large enough bolus and it's actually in the esophagus, it can cause tracheal compression. So don't forget BLS maneuvers. I had an 8-month-old who swallowed a piece of meat at a barbecue, went into respiratory failure, respiratory arrest, was bagged. They were able to bag around it. And we looked in, we couldn't see it, and I go, oh my God, it must be in the esophagus. And it turned out the kid started, retching, so we flipped the kid over and did backflows, and it popped out of the mouth. So, and another kid ended up getting trached, but it was actually in the esophagus. So don't forget about the esophagus, especially if you go in and look and it's not there. You don't see it above the cords The narrowest portion of a pediatric airway is the cricoid. It's typically going to be, it may be above the cords, but it could also be below the cords. So that's why back blows and chest rests also may be helpful. Okay? Now, one thing about foreign bodies, they never look like what they look like going in, right? You know, you say it's a piece of popcorn or a Super Bowl or whatever, it's covered with blood and saliva. So that's how I used the McGill's, went in, removed the foreign body, begin bagging. So here you are looking at this thing, and it never, like I said, it never looks like that. You go in with tips closed. You're gonna, the reason I go over this is because this is something you see not infrequently in children. You remove it. I would look around, you might have to suction here and make sure there's not a second foreign body. Sometimes they put more than one in, okay? But here's a hint, okay? If you go in and look, and it looks like a mess, like there's some globular thing in front of the airway, go ahead and take it out, okay? You're not gonna remove, you know, their tonsils or anything like that. I've had, you know, especially paramedics say to me, I didn't want to remove it because, you know, it was bloodied. It looked like it was a mass or something. I said, don't worry about it. There's not that many masses in children's, you know, upper throats, and just take it out. So let's talk about RSI, and the 7 Ps are typically what we think about, and I know you guys are masters in RSI. So I'm going to run through this and try to just highlight only those things that are appropriate for kids. Order and steps are dependent on a clinical situation. In most situations, you can do your full RSI, right? Meaning you preoxygenate, put the nasal cannula in, right? You get set up for your sedation, you give sedation, you follow that with your paralytic. Now everybody stands and waits for 45 seconds to a minute for the patient to you know, get defasciculated, and then you initiate the RSI, right? Every now and then there's a problem. I had a 10-year-old come in, asthma, was totally purple, was peri-arrest, had a heart rate of 50, jaw was clamped. There was no way for me to do endotracheal intubation without paralyzing him, but I was afraid to. The nurses were trying to get an IV line. It wasn't happening immediately. Any thoughts on what to do there? Is there a drug that you can give IM that will paralyze them?
Ketamine, but it takes a while.
Well, okay, ketamine could be used, but it won't paralyze them. But succinylcholine can be given IM. So what I ended up doing is giving him 3 per kilo of succinylcholine in his lateral thigh, paralyzed him and intubated him, and it took less than a minute, okay? So just think about that. Every now and then you'll have it's almost never you'll have that situation, but I just throw that out there for you because it's really handy if you remember that. So succinylcholine can be given IM.
Is the dosing different if it's IM? So you said 3.
I wanted to make sure he was paralyzed as quickly as possible. You could do 2 to 3. Big mistake that's made in children is you try to do 1 or 1.5 like you do in adults.
What's the only rule about paramedics? Never be too paralyzed.
Never be too what?
That's a good point. You can't. But I will say that, you know, make sure that you give an adequate dose for children. I've seen kids pass metabolizers within 3 minutes. They're, you know, we're screwing around or there's issues that they're already not paralyzed again. And you don't, you know, repeated doses aren't good. Or you try to avoid them. I told you this before, kids do SAP pretty quickly. I use high flow nasal cannula all the time for every single case, and I absolutely love it. It's worked great. So 15 liters. There's not good rules. Any child, you could do 15 liters. You could probably do it 15 liters on a newborn, frankly, but I go to 5, and then as soon as they're, you know, over 1, I move towards 15 liters. Some do infants 5, kids up to 2, 10. There's no rule here. You know, I say it's such a short time. You can do anywhere between 5 and 15 for young babies, otherwise 15. Atropine, there's really no great evidence to support the routine use of atropine. There are some potential downsides of atropine. They can be arrhythmogenic, especially for the ventricle. And they've done studies in the electrophysiology lab and shown that atropine can promote ventricular fibrillation. So we wouldn't want to give it routinely unless it truly had a benefit. And the studies that have been done have not been great, but it just kind of highlights the fact that the real bad boy is hypoxia. That's what's going to lead to bradycardia. So you want to treat hypoxia and pre-treat with oxygen. There's also no minimum dose. I was always taught, you know, if you don't give 0.1, then the kid's going to become bradycardic and die. And that's been debunked. So you just do it on a milligram per kilo weight. I'm not going to go into all the different sedatives, but I like ketamine. You can see I like ketamine, but ketamine can be used in almost any case. Typically, if there's hypotension with trauma, especially multiple trauma, I think ketamine probably would be the drug of choice. You could use etomidate because it's got less cardiovascular effects, although with severe hypovolemia, it can cause hypotension, so that is a concern. Head injury without hypotension, you can use etomidate, that would be fine, thiopental, midazolam. And head injury with hypertension, I personally would probably just go to ketamine. There was some concern that ketamine will increase your intracranial pressure. The issue, though, is that it maintains your mean arterial pressure, so that maintains your cerebral perfusion. So that actually tends to be more important than any concerns about a mild increase in ICP, okay? And so that's the bottom line there. Succinylcholine, the take-home point is for children, just use 2 per kilo. Don't mess around. And you can even go higher, all right, as I mentioned in that one case. Rocuronium, typically it's 0.6 to 1.2. I just use 1. It's so much easier to calculate. Just say 1 per kilo, and I use that. In terms of intubating conditions in children, it's been found that succinylcholine gets you intubating conditions a little faster than with rocuronium. Some institutions don't use any sucks. We use sucks in the emergency department, except for those with true contraindications. And those would be stroke patients or had paralysis, children with CP, I wouldn't use it on. Or I would try not to use it on children with muscular dystrophy. So you go with rocuronium. This is like your worst nightmare, unless you also had a hemophilia. But mom rushes into triage with a 2-year-old boy with craniofacial abnormality. The child's obtunded, gasping, you know, that gasping type respirations. Nurse calls for a physician, places him in the resuscitation room. You attempt bag mask ventilation, but you really aren't able to do it very well. And the sat keeps dropping, and ET seems to be impossible. Now this is a situation where you need all hands on deck and you need your difficult airway. What would you use? Yes?
Maybe try to throw an LMA in there since it's a little more forgiving of airway and anatomical differences.
Okay, so LMA is a great choice here. It really is. If you had airway obstruction, don't forget prone bagging. You know, if you have somebody with like some type of well, it used to be epiglottitis, we don't see it anymore in children, but if you had swelling in the upper airway, you could flip them and try to bag them prone. But in this case, you can't get a good seal because of the micronathia, so I think using an LMA is the way to go. And this is another one of your worst nightmares. There's basically no neck and all tongue. These certain patients like this with galactosemia, you see kids with Down syndrome, have their tongue is more extra oral and it's just gigantic. So again, jaw thrust, using a blade, a good blade, probably a bigger blade than you feel that you need would be helpful in that instance. So how do you know you're in trouble? Typically, you're not going to do a Malampati in a kid because you're going to come in an extremist. But when you intubate, this is when you know you're in trouble. You don't really, this is you're really in trouble, grade 4. And again, in operating room settings, the jaw thrust can move you down at least 1 Cormack and Lahane grade. All right, so it actually works pretty well. Or after 3 attempts, you can't get it. So you'd consider OP nasal airway bag mask for most cases. In this case, that's going to be problematic. I think a supraglottic airway or a laryngeal mask airway is really the way to go. We don't typically use, you could use a lighted stylet, they go down. Video laryngoscopy could be used, and that's been used very successful in these kids with craniofacial abnormalities. So Lightscope, as an example, you may get, just because of the psychomotor action of that Lightscope, and it's a little bit more curved, that may get you a little bit more visualization than with your standard direct laryngoscopy. Now, some good news is that on the Broslow tape, it gives you all the sizes of LMA. So you can use a Broslow tape to size your LMA as well. But this is the old LMAs, but you're typically going to have the a disposable. These are eye gels. The King only goes down to a 2, although I hear they're coming out with smaller sizes now. And the Air Q is very much like just the LMA. And essentially, you put it in, you're going to place it so you can directly at the laryngeal inlet. Here's an example of being in place. If you notice, the black line is always towards the head. You put it in. You can do it from the foot of the bed to the top of the bed. And you go in, put it in until resistance is met, and then you put in the correct amount of air, and you should see it rising out of the mouth. Has everybody put these in? A few of you, yeah, it looks like a lot of you have. So you go into anesthesia, they use them all the time now. But if you could put one in a kid in the operating room, that's the best. Again, you take the cuff down, make it like a spoon, you put it, just follow the curve of the palate to meet resistance, and then you blow it up. They're really cheap, they're disposable. There's the Unique, there's the Supreme. Again, there's different sizes, but the Broslow tape has those sizes, which is super cool. All right, so you'll be able to see the LMA size on there. Typically, we'll say it by weight on it, so you should, once you've got the Broslow weight, you should be able to size it appropriately. Here's the Air Q. The sizing is pretty much the same. The eye gel, this is an elastomer, you don't need to blow it up. There's not a lot of studies on the eye gel, there are more and more. Here's the King, it's a single device supposed to go in the esophagus and you blow up the balloon, and it tells you exactly on the side how much air to put into that balloon. All right, let's talk briefly about video laryngoscopy. There's a lot of studies in video laryngoscopy for kids. Here's the bottom line with video laryngoscopy. You get, for challenging airways, probably video laryngoscopy is the way to go. And you may want to go directly to video laryngoscopy. We do know for standard routine intubations that it takes longer to intubate somebody with video laryngoscopy, all right? So DL is fine. We typically, if it looks like it's a standard airway, we always go with DL. We have the video laryngoscopy available if we need it. If on the first pass we're going, this is a real problem airway, then our next attempt is with video laryngoscopy. In some ERs, they're going directly. I don't know what you use in adults. We're still DL, we're still doing the same with our adults. Are you doing that here, or are you going directly to video?
Provider preference.
Yeah.
It's provider preference. Ron Walls, who you know, who does the airway course, he says you should go just use video laryngoscopy. I don't feel like you need to all the time, but anyway. So there's no actual any contraindications to it. There's 3 major devices that have all sizes. The CMAC has all sizes. Glidescope definitely has all sizes, and the AirTrack has all sizes. Most people have a lot of familiarity with the Glidescope, and so for that reason, I'll just show you a video of the Glidescope, and then I'm done with this segment here. So if you notice, and I think everybody uses it, notices there's a little bit more cranking with the glide scope. You know, with video at direct, you want to lift directly up. What you're going to see here is you see the cords at the bottom. And what they're going to do is they're going to squirt in a little anesthesia. And what else you're going to see is a laryngospasm. So they're going to squirt. And then you'll see, whoops, I think I'm beyond that. Oh yeah, now you'll see the laryngospasm. Did you see that? I went all the way up. So generally what happens, it's a contraction that goes from the arytenoid cartilages up. Usually it's very transient, laryngospasm. And again, once the endotracheal tube is in with the glide scope, as you know, you've got to hold on really tight. Once you get through the cord, you begin backing out that stiff stylet, and then you continue to push it through. And it's the same in adults, but in kids, it's a little bit more problematic. You gotta, what I try to do is I stabilize my hand on the side of the child's face while I'm holding on to the endotracheal tube to keep it from pistoning, because what happens is you pull that stylet out. If you piston even a centimeter, you're going to dislodge the tube. Remember, the tracheal length is very short in children, and so that's the biggest issue. Okay, so a couple things we talked about. One is have tools available for you, like Brasso tape, all right? Or you can use your smartphone, but you're going to need some tape to measure them. I would do cognitive practice. It will help alleviate a lot of anxiety when a kid comes in. So you see a 5-year-old, you go, oh, Marianne said a 5-year-old is 20 kilos, right? Or 5 uncuffed, 4.5 cuffed. You know, and I just practiced that and practiced doing some dosing so that when I see a kid that's in extremis, I'm able to act upon that, okay? And so cognitive practice helps you. The other thing is, I'm going to put I don't have any stock in this, but I help plan with FACEP, the Advanced Peds Assembly, every year. It's a fabulous place for one-stop shopping for you guys as emergency physicians to get updated in everything pediatric emergency medicine. We have skills, we have pediatric ultrasound, we also have a single one-day, it's called Essentials. We're probably going to call it something else now, like fundamentals or building blocks. But the bottom line is one-day soup to nuts peds emergency medicine, from airway management all the way through like non-traumatic ortho and surgical emergencies. And then the next 2.5 days are cutting-edge pediatric emergency medicine. This year it's going to be in Vegas. It's in April, so it's really a fun conference. And again, it can be one-stop shopping for you. And we know that skills wane pretty quickly, so if you don't use it, you're going to lose it. And since most of you are not going to use it, hardly at all, my suggestion is it's a nice once-a-year stop to update you on things pediatric. You want to plan for stepwise management and have devices available to you. Remember, job thrust is your friend and don't overbag. And then have a difficult airway kit and a process. And with that, I'm going to end with the California sunset, just to remind me of where I'm from, and field any questions. So we're going to take a little break, and the next section will go pretty quickly. Any questions? Hopefully, thank you. Hopefully that was helpful for you. I hope I gave you a few hints, right? Don't get too small a blade, guys, okay? Right? All right. We're gonna, should we just, why don't we take a stretch break? Yeah, why don't we take like a 5 minute stretch break?